that fluid should be a multiple electrolyte solution. It should be isotonic. It should be crystalloid solution. It could be given intravenously. It should contain any of these combinations: sodium chloride, sodium gluconate, sodium acetate, potassium chloride, and magnesium chloride. The basic idea is that it should restore electrolyte balance. That is one idea. It should normalize our pH. It should provide hydration. It should replace lost body fluids and electrolytes. And it should normalize electrolyte concentrations, and it should regulate acid-base balance. So as you all know, in our ICU, this is what we basically see. We see hydration, we see electrolyte, we see acid-base balance, and that is an ideal. So an ideal electrolyte solution, crystalloid solution should be like this. Let me tell you, we don't have an ideal crystalloid solution, but we have a number of crystalloids with various advantages and disadvantages. The basic difference between balanced crystalloid and the other crystalloids that we are using, that for example 0.9% NaCl is Na and Cl. In balanced crystalloid solution, chloride ions are replaced. Chloride ions are replaced with bicarbonate or buffers to reduce the changes in acid-base balance. This we are going to discuss in detail. So why should we use balanced solutions? I am going to first tell you some of the disadvantages and the evidence which we have against the use of 0.9% saline, because that's the most common fluid that we use. And also then we are going to discuss some evidence. So as intensivists, we always do things in our ICU which has evidence, right? And backed by logic, backed by evidence, and backed by good clinical practice. So a balanced electrolyte solution is a physiological electrolyte pattern of plasma in terms of cation and anion concentration, physiological osmolarity, and it should achieve physiological acid-base balance, and chloride should be in the range of normal physiological value. So this is one indicator balanced electrolyte solution that we are going to study today, which is Cabilite. There are other balanced crystalloid solutions available as well. For example, Plasmalite, Hartmann solution, even Ringer lactate is supposed to be a balanced electrolyte solution. So let's study the composition of this solution compared to plasma. So it will tell you what a good electrolyte, good IV fluid should be. So good IV fluid should have a sodium concentration which should be close to plasma, a chloride concentration which is close to plasma, a potassium which is close to plasma. It should have buffer so that the fluid does not cause metabolic acidosis. It should have little bit of electrolytes, for example magnesium, and osmolarity should also be mimicking the in the plasma range. So let us compare some of the problems which point saline has compared to let's say Cabilite as a representative of multiple electrolyte solution. The principal problem with saline is subnormal sodium and subnormal chloride. If you see the chloride concentration here is 154 compared to 98 in balanced solution, and sodium is 154 compared to 140, so these are the physiological values which Cabilite has, and these are the values that we have in our saline, and this is the basic root cause of the problem that we sometimes face, which we are going to discuss in favor of balanced electrolyte solutions. So saline has 154 sodium and 154 chloride, and this is the primary source of the problem that we face. It has a supranormal sodium concentration, which means that if you give too much of it, your sodium is going to climb. If you see we are working in ICUs, and after second or third day, we all find our sodiums to be around 152, 153, right? And that is what normal saline has, isn't it? So when we keep struggling with lowering the sodium, and then so that's a lesson, right? So we are very sensitive about sodium, but what we don't usually monitor is chloride. So chloride we don't usually note. We don't go down in the EBG and see what chloride level is. But the problem is chloride. Sodium is less of a problem. Chloride is more of a problem, and that is why we favor balanced electrolyte solution. Let's see the problems with. These are the problems which saline has, and these are the evidence and based on studies that has accumulated over the years. So this is taken from a very important publication which was called "Should chloride-rich crystalloids remain the mainstay of resuscitation fluid?" So let's see what problems saline causes. So saline causes metabolic problem. What metabolic problem? It causes hyperchloremic acidosis. It can cause possible. These are problems that have been identified based on animal studies as well as clinical trials. So it can cause possible damage to endothelial glycocalyx. It can cause increased interstitial fluid volume leading to edema. Renal. The most important evidence that we have against saline now comes from the kidney, and I am going to tell you some few of the trials on the renal complications of saline. So what excessive saline administration does to kidney is that it causes renal edema, capsular stretch, it causes renal vasoconstriction, decreased renal blood flow, decreased renal tissue perfusion, decreased GFR, urine volume and sodium excretion. So there was one study in which compared, let's say you have two patients, you give one patient 1 liter of crystalloid solution, balanced crystalloid, other you give 1 liter of saline. It was found that patients who were given saline passed less urine because of this renal toxicity effect, and that leads to sodium retention and that leads to water retention. Gastrointestinal. So saline compared to balanced electrolyte solution in many studies were shown to have more gastrointestinal edema. Very important evidence comes from surgical patients. To those who are practicing anesthesia, I will give you a couple of slides on how balanced crystalloid solutions can fare better compared to saline. Hematological problems, increased intraoperative blood loss. There is a very interesting study which compared two sets of patients, post-surgical patients who were given saline versus crystalloids. We found that saline group had more intraoperative blood loss, increased need for blood product transfusion, clinical outcomes. So, especially in surgical patients, cause increased post-operative complications and increased mortality, proven in some of studies, and increased incidence of acute kidney injury and need for renal replacement therapy. So these are some of the problems that saline has based on animal studies as well as some clinical problems. So, how does saline damage the kidney? What adverse effect? I won't say damage, have some adverse effects. It causes hyperchloremia, it causes vasoconstriction, it causes decrease in glomerular filtration rate. The chloride enters into the macula densa and causes depolarization of basement membrane and release of adenosine. All this leads to increased renal tubular chloride, decreased urine output and sodium output, as well as leading to acute kidney, more incidence of acute kidney injury. Compared to that, what advantages balanced crystalloid solution like Chloride may have? Balanced base excess. Saline causes hyperchloremic metabolic acidosis. Chloride has a buffer. So, what buffer has? It has acetate. So, what happens to most balanced crystalloid solutions will have a buffer, either in the form of acetate or in the form of gluconate. Acetate metabolizes to bicarbonate in the blood, and then that is why it decreases the incidence of hyperchloremic metabolic acidosis, which saline has. It is calcium free, so you can give it along with blood. It is lactate free. So compared to ringer lactate had lactate, and when you give infused lactate to patients, it causes increase in lactate in the blood. Most of the time it may not be clinically relevant, but it may become clinically relevant in patients who have decreased lactate clearance, for example, your chronic liver disease patients. It maintains acid-base balance better than saline, and it reduces the risk of metabolic acid. Balanced base excess reduces mortality. So if you see in a study, they measured base excess in the ABG, and they found that patients who had more base excess had higher mortality, and they neutralized all other factors between the control and the study group and found that saline-induced balanced increased base excess leads to increased mortality. So, I think I've already told you. So, saline, major drawbacks. The most prominent problem with saline is that the concentration of chloride is 50% higher than in the plasma, and this leads to hyperchloremic metabolic acidosis. Electrolytes such as potassium, calcium and magnesium and also buffer are lacking. So NaCl has only sodium and chloride, and osmolarity and concentration of sodium are marginally higher. So clinically, what does hyperchloremic metabolic acidosis leads to? This is an important study where the patients were infused large amounts of normal saline based on their clinical condition. It was found that Large infusions of normal saline leads to persistent acidosis, delayed urination, decreased abdominal comfort and pain, nausea, drowsiness, decreased mental capacity to perform complex tasks. Ringal lactate. The problem is ringal lactate. So ringal lactate is also a balanced solution. But let's study what problem ringal lactate. And these have clinical implications because there are certain subset of patients in which your choice of fluid will depend. For example, a patient who has already developed high chloride or hyperchloremic metabolic acidosis, you will not give normal saline. A patient who has got hypochloremic alkalosis, you will give normal saline. A patient who has got liver dysfunction, you will not give ringal lactate. A patient who has got already higher lactate solution, you will not give a ringal lactate. That is why we should know what fluid we are giving. So let's say ringal lactate. Problem with ringal lactate is it's a hypotonic solution. You see sodium 130. So we have a big neuro ICU. You will not like to give hypotonic solution to a patient, and this problem happens with balanced electrolyte solution as well, and I'll come to that. So unfortunately, ringal lactate is also not balanced solution. It is also not normal. Chloride level in ringal lactate is also on the higher side. It has got potassium. It has got higher levels of chloride, and it has got lactate. The most important problem. Not that in most clinical situations they may not transform into strong evidence. They are not contraindication. They are just a guide, right? So lactate increases mortality, that we all know. All our sepsis patients, the first thing we do in ABG is we see lactate, and obviously if lactate is raised, you will not like to give a patient electrolyte solution which already has lactate in it. Number of guidelines have now endorsed use of electrolyte. This is a surgical group in the UK, and it says that because of risk of inducing hyperchloremic acidosis in routine practice, balanced solution should be used. It's ERA Society, the Enhanced Recovery After Surgery Society guidelines. These recommend that high-risk patients should be given balanced crystalloid over saline. And evidence for the level of this is quite high, and they recommend that as of now, the recommendation towards giving balanced electrolyte solution is quite strong. So we have seen lot of surgical ADQI. Acute Dialysis Quality Initiative Consensus Guidelines. They state that presently balanced solution, salt solution may be a reasonable default choice in acute kidney injury patients. So now we are going to review some evidence. So although both saline and balanced crystalloids have been administered to patients in clinical practice for decades. Now the problem, saline is not going to go away. We are going to continue to use saline. This talk is not to discourage you to use saline. Initial resuscitation should be normal saline. Most of the patients will need normal saline, but then of course balanced crystalloid is a good default option. So I think this all we have already discussed. Higher rate of acute kidney injury, renal higher. So it has been shown, to cut it short, in studies that use of exclusively normal saline leads to higher rate of acute kidney injury, higher rate of renal replacement therapy, higher rate of and in some studies increased mortality. Now, extremely important study. This is one study which evoked lot of interest in favoring balanced crystalloid solution. This was a study published in NAGN, a very recent study published in 2018, I think 18 or 19. And what they did was, I'll tell you how the study was done. Fantastic way of doing a study. So they took 5 ICUs. In one ICU they gave balanced crystalloid. So normally what you do in a study, you randomize patients, one patient into this arm, one patient into this arm. What they did was randomize entire ICUs. They randomized one ICU to receive normal saline, one ICU to receive balanced crystalloid, and after 2 months the reverse flip-flopped. So that is why the evidence which came from this study, and almost 15,000 patients were studied in this study, and that is why the evidence which has come out from this trial is taken very seriously. Also, just like any other trial, it also has its criticism. So the primary outcome in this study was the proportion of patients who met one or the more criteria, which is kidney event, mortality, and so on. So I will cut it short and give you the gist of the study. It was called SMART trial, right? Fantastic novel design, and they applied to the permission to the UK government for waiver of consent. So every patient admitted to the ICU consent was waived off and that the patient entered the trial. And that is why they could complete the trial of 15,000 patients in just 2 years and come out with fantastic evidence. So the evidence which comes from this trial is the use of balanced crystalloid solution rather than saline resulted in an absolute difference of 1% in favor of balanced crystalloid as the primary outcome. Now you would say what 1% is very small, but it's not small because every patient receives fluids. Millions of patients receive fluids. So if you multiply that mortality by number of patients that are being given IV fluid, the mortality difference is huge. So it's not a small difference. And this finding is the same finding which another trial called SALT trial showed in ward patients and in surgical patients. So these results suggest that the use of balanced crystalloids rather than saline may prevent one patient among every 94 patients admitted to the ICU from the need for new renal replacement therapy, persistent renal dysfunction or death, which is huge. So you save one life, maybe one life or one morbidity out of 100 patients. And we give saline to IV fluids to everybody, and that may transfer to a large mortality and morbidity difference. Now the difference outcome appears, it's not just surgical patients who benefit, this difference outcome in this particular study, I think there's mosquitoes there. So in this particular study, the outcome appeared to be greater for patients with sepsis and patients who received large volume of isotonic crystalloid fluid. So we have sepsis patients who receive liters and liters of fluid, and this study showed that. So balanced crystalloids. So are balanced crystalloids to be given in every patient in all clinical scenarios? No. There are a number of clinical scenarios in which saline should be given. So I don't want anybody to take home the message that we are against, we should not be using balanced crystalloids, saline solutions. So saline solutions will be better in the first 24 to 48 hours. All initial resuscitation may be given with normal saline, but you have an option of giving balanced crystalloids. Also, neurological patients who have high ICP should not be given balanced crystalloids as of now because of their slightly hypotonic nature. So brain injury patients should be given normal saline unless they develop severe hypernatremia. Patients who are being resuscitated and who have alkalosis and hypokalemia. For example, patients who have vomiting. So patients who have vomiting, they develop hypochloremic metabolic alkalosis, and these are the patients who should not be given balanced crystalloids, and for them normal saline should be better. So chloride restrictive strategy, right? So we have now come from fluid restrictive strategy to chloride restrictive strategy. So what is fluid restrictive strategy? We realize that we are giving too much fluids in our ICUs, and that is why we attend lectures and seminars where our teachers tell us that we are giving too much fluids, and at the end of third and fourth though we should have equal volumic balance. So a chloride restrictive strategy, these are two studies which show that a chloride restrictive strategy means that you give less of normal saline and more of balanced crystalloid, leads to better outcomes, lead to decreased length of stay, decreased need for renal replacement therapy, decreased incidence of acute kidney injury, decreased length of ICU stay, and in the second study, decreased death. So another representative study, for example, in patients with diabetic ketoacidosis. So patients who are seeing, we get a lot of patients with diabetic ketoacidosis. One study focused on use of balanced crystalloid solution in diabetic ketoacidosis, and it came to a conclusion that patients with DKA resuscitated with balanced crystalloid instead of normal saline had faster initial resolution of metabolic acidosis and less hypochloremia with transiently improved blood pressure profile and urine output. Right? And we all know that our DKA patients require huge amount of fluids, and at the end of third and fourth day, many of them develop hypochloremic metabolic acidosis. So major complications, mortality and resource utilization after open abdominal surgery. Another study which tells you that among hospitals, a calcium-free balanced crystalloid for replacement of fluid losses on the day of major surgery were associated with less post-operative mortality. So pre-operative and post-operatively, I have given you so much evidence that balanced crystalloid may always be better than normal saline in most locations. Yes, potassium. So when we are using balanced crystalloid, we must know what our fluids contain, whatever fluid we are using. So when we are using lingual lactate, we know it has lactate and potassium. Similarly, when we are using Cabilite or Plasmalite, we know that it has potassium and should not be given to patients who have elevated potassium levels or who are undergoing hemodialysis. All right. Another study which showed that patients who have who are resuscitated with normal saline and continue to receive a lot of normal saline fluids have more retention of fluid and have a reduced urine volume compared to patients who are in which we give balanced electrolyte solution. What happens in sepsis? This is a graph which shows 4 very important studies. You see these black dots and you see this. We should learn how to interpret our study results. So this is a way where you can get information about a comprehensive information about combining various studies. So we have 4 studies, 1, 2, 3 and 4. This dot means neutral, this means favors balanced electrolyte solution, and this means saline. All our dots are on the left side of our dotted line, which means all these studies have favored the use of balanced electrolyte solutions for treatment of critically ill patients in the ICU. Association with intravenous chloride load during resuscitation and in-hospital mortality among patients with SIRS, which means systemic inflammatory response syndrome. The reason why I put this slide is that we are seeing so many sepsis patients, pancreatic patients, burn patients, and all these patients have systemic inflammatory response syndrome. So this study studied association between intravenous chloride load and hospital mortality, and the results of the study was that patients in which chloride load was less, and obviously this would have been patients who had received less of normal saline, more of other fluids, balanced crystalloid fluids, had lesser mortality. Not only they had lesser mortality, they received less amount of crystalloids compared to the saline group. So if you use balanced crystalloids in patients like this study shows that you will be able to achieve your goal in slightly lesser amount of fluid to be given, and we may end up with a better patient outcome. So I think one of the last 2 slides. So the question is, what should the take-home message be? I've shown you and I've shown you just maybe 7 or 10 studies. If you look at the literature, it is replete with dozens and dozens of trials which have shown benefit of balanced crystalloid solutions. Now, in spite of having those 15, 20, 25 trials favoring balanced crystalloid solutions, the final result is still not out, which means this was a very important discussion which asks a very important question. Balanced crystalloids or 0.9% saline in sepsis beyond reasonable doubt. In spite of having so much evidence, the reason why we have not come out with one guideline that all patients should receive crystalloids is because every patient needs IV fluids, and we must have more evidence before we come out with a guideline. The other problem is we don't know which patients require what fluid. So the categorization is still broad. We don't know exactly which patients will better benefit with balanced crystalloid solutions and which all patients will benefit with normal saline, but we do have broad categorization, as I already pointed out in the study. So there is proof, there is reasonable proof, there is strong proof, but as of now proof beyond reasonable doubt may be lacking. So pro for balanced crystalloid is that there is growing evidence, and fluid is such a thing which interests everybody, and there were so many investigators do so many trials on fluids that we have 1 or 2 trials coming up every 1 or 2 years. So we have growing evidence that suggests that using balanced crystalloids rather than saline may have the potential to reduce morbidity and mortality, and that is what we want in our sepsis patient. Reduce mortality, morbidity, reduce length of stay, reduce complications, and I think, in my personal opinion, after the initial resuscitation phase, patient should be evaluated on what kind of fluid a patient needs. So if a patient is having hyperlactatemia, you should use lactate-free fluid. If patient has metabolic acidosis, you should switch to balanced crystalloid amount. If the patient is developing fluid overload, better give a balanced crystalloid solution. If the patient has alkalosis and hypochloremia, better give normal saline. Give normal saline as the initial resuscitation fluid, and later on switch to crystalloid is an option. Thank you very much. And if anybody has any questions.